Hello, roommates. Come on in. Come on in. Come on in, roommates. Hello, hello, hello. Come on in. Come on in. We have a treat. Hi there. Thank you for joining. We have a special guest. Hello, hello. Come on in. Come on in. Come on in, roommates. We have a wonderful treat. A wonderful treat. Hello. All right, we got a special guest, guys. Come on in. Come on in. Happy Wednesday. Come on in. Come on in. All right. We are inviting our guest in right now. I'm super excited to be here this evening. Come on in. Hey, roommates. I see some new faces. Welcome, welcome, welcome. Okay, the requests have come through. Wonderful. One moment. Come on in, everybody. Come on in. Okay. I think Dr. Patrick has asked to join. I think I accepted it. Hi. Hello there.
Hi.
How are you?
I am well. How are you?
I am well as well. Thank you so much for joining us.
Sure.
And we are just going to get started in just a moment. I am allowing my roommates to come on in and am just super excited to be here with you.
Sure.
So once we get a few more people in the room, we will get started. And we will be taking some questions from our roommates this evening. So you'll see me pivoting between, looking directly at you and bringing in some of the questions from our roommates. So super excited that you're here, Dr.
Sure.
Patrick.
Thank you for having me. Sure.
Yes. All right, roommates, we are going to be getting. But before we do, as we normally open up, Roma has it with inspiration and biblically based scripture. Tonight, I'm going to start off with some uplifting scripture regarding illness. And the verse is going to be coming from Psalm 6:2, and it reads, "Have mercy on me, Lord, for I am faint. Heal me, Lord, for my bones are in agony." So I want you all to be reminded to focus on your health, but also keep your eye on the Lord when you're going through. Do not become so faint that you forget who's in charge of all of this. But without further ado, I am going to introduce our wonderful house guest today. She is a fellowship trained breast surgeon. She specializes in breast surgical oncology. She is an American board certified general surgeon. Her education and experience includes a fellowship in breast surgical oncology from Northwestern University, a residency in general surgery from the University of Florida, Shands, Jacksonville, and she attended medical school at Meharry Medical College. So at this time, roommates, I want us to give a huge round of applause for Dr. Jilma Patrick. And then that's when the sounds and stuff goes off.
Thank you, Tamika. Thank you. Thank you for having me.
Oh,
Thank you.
it is such a pleasure. And we'll get off into, some of my appreciation a little bit later. But we're going to jump right on in, Doctor. And I like to start off with all of my guests by asking if you can give a little bit of historical context about you and you can share as much or as little as you would like. But I think our roommates will really be inspired to hear about who Dr. Patrick is and how Dr. Patrick
Oh
became.
gosh. Well, gosh, you gave a pretty good biography there, but I'll just mention a few other things. So I was born in the Virgin Islands, and I went to college in Baltimore, as you mentioned, at Morgan State. Um, I went to school on an athletic scholarship I used to run. And then after college, I actually did some breast cancer research at the NIH for about a couple of years. And then that's what kind of really got me into breast cancer, the field of breast cancer. And then after that, I did some additional research at the University of Maryland in
Okay.
Baltimore before going off to medical school. So medical school, then residency. I knew I wanted to be in the field of breast cancer, and I met my breast surgeon in medical school, and she greatly inspired me with the work that she has done and the relationship that she has with patients. So that kind of really inspired me to go into surgery.
Mm.
So I did surgery, and then breast surgical oncology fellowship at Northwestern, and since then, for about 9 years, I've been practicing here in the Chicago area. Recently just opened in my practice, so about a few months ago in the South Loop. So just
And
trying to advance things.
congratulations
Thank
on
you.
the opening of your practice. I'm sorry. Go ahead.
No, thank you. And that's pretty much it from where I came from and where I am today.
And a little birdie told me that you're also a mother. How do you juggle being in the profession that many of us idolize, right? You know, you ask young children, what do you want to be when you grow up? And kind of the first thing that people say right off the bat is like a doctor. And I know that that has to be a huge feat. I remember when I went to college, my major was biology initially, and my first semester, I messed up all the way around the board, so I changed my major real
Sure.
quick.
Sure.
So I know that it could be difficult with studying and balancing private practice and things like that. So, do you want to kind of give us a little snippet on how you balance that?
So I think I always look back on my past, and I think one of the most important things that helped me throughout my entire life and my career is actually being an athlete, and because it taught me a lot, discipline and goal setting. So that experience has led me throughout my entire career. So um, in life in general, there's going to be a lot of obstacles and a lot of it's not easy to get to the goals that you're trying to accomplish, but what is easy? So
Mm,
it's just a lot of determination that I developed early on in life. And in terms of my kids, yeah, it's always motivating. I always want my kids to be better than I am. So, I motivate them to be interested in whatever interest that they
mhm.
have, and I'll always support them whichever route that they choose.
I, I love to hear it. And to your point, life is a balancing act. So whether you have children involved or not. So thank you for sharing who you are and kind of what led you to become a breast surgeon. That is deep and that is wonderful. So we're going to jump on into, like while we're here, and we're going to talk about things in the medical field as it relates to breast cancer. So can you take this time to kind of define and educate myself and the roommates on what exactly is breast cancer?
So in general, when we talk about cancer, so cancer is really abnormal growth of cells. So these are cells that are growing abnormally. They're multiplying. They're invading other structures, and this is what we describe as a malignancy or a
Mhm.
cancer. So regardless of where in the body it is, that's in the breast. Breast cancer usually starts from either the milk ducts, where we carry milk from the lobules. The lobules is where we make our breast milk, and the milk ducts take the breast milk from the lobules to the nipple. So breast cancer can either start in the lobule, or most commonly it starts in the milk glands. Um, Sometimes you have different types of breast. There are different types of breast cancers. Some breast cancers we said non-invasive. So this is just a localized cancer within the milk duct that doesn't spread to other parts of the body, whereas most commonly we have what we call invasive cancer, which can invade the surrounding tissue as well as spread to the lymph nodes or other parts of the body.
So it sounds like it could be centralized in some places where, and I know we'll get into like treatments and
Sure.
stuff like that. You are the expert, so I definitely guide me. I don't want to, I'm following your lead tonight,
Sure,
but
sure.
it's what I heard you say. It sounds like that at some juncture, in some cases, the cancer can be centralized and maybe not as evasive. And I think one of my aunts just had a bout and found that she was in stage one.
Yes,
And they
yes.
were able to kind of just go in, do a surgery in a centralized place, and then do radiation only. So, can
Sure,
you kind of just help us understand that from maybe like a medical standpoint?
sure,
Like
sure. So basically, there are different stages of breast cancer. We start from stage zero. When we say stage zero, this is the type of breast cancer that we call non-invasive breast
hmm
cancer. It's breast cancer that really stays within the milk
hmm
ducts, and it spread to other parts of the body like the lymph nodes or the or other parts like the lungs or the bones. It just primarily stays in the breast, and we call that stage zero, or non-invasive cancer. Also, we call it ductal carcinoma in situ. So if the cancer have broken out
hmm
of that centralized area, that's when we call it invasive breast
hmm
cancer. And when you have invasive breast cancer, it can be different stages. It can be stage one, stage two, stage three, stage four, based on many different factors. When we describe early stage breast cancer, that's usually stage one, and sometimes even considered stage 2A. And this is breast cancer that is just localized to the breast. Um, sometimes these days the staging has changed so much because it depends on so many different factors. But stage two breast cancer is where could be where the cancer is a little bit larger, or we just have cancer that has spread to the lymph node, and we can describe that as locally advanced in some cases. Stage three is a larger size cancer, maybe more lymph nodes involved.
hmm
And stage four is when you have breast cancer that have spread outside of the breast and outside of the lymph nodes under the arm. So other parts of the body, such as the lungs,
hmm
the bones, the liver, these are most common areas where breast cancer spreads after it leaves the breast. Um, it takes that's basically a very basic version of it. A lot of factors go through when we determine stage, but that's a pretty basic version. I think the key thing to understand is that the earlier that breast cancer is diagnosed,
hmm
women have the best prognosis. You have the best chance of living longer. When your
hmm
cancer is diagnosed at stage zero or stage one,
Yeah.
a 5-year survival rate
Wow.
is almost 100%. It's 99%. Now this is with treatment, right? There, you undergoing the recommended treatment that we suggest.
hmm
After the cancer has spread to the lymph nodes,
hmm
the survival rate lowers a little bit, and that lowers to about 86%. That's a 5-year relative survival rate. And as it becomes more advanced to more lymph nodes or a larger size, that is as or other places involved. So the key is diagnosing earlier, where you
hmm
have the best prognosis.
Yes, I mean that definitely makes sense. You said something a moment ago that I really wanted to piggyback on, and which is women or men. So I know that there's a myth that well, sometimes people think that men cannot get breast cancer. So can you maybe toggle on that a little bit, and then
Sure.
even tell us maybe some of the statistics
Yeah.
around male breast cancer?
It's a tough topic to talk about with men, but I don't think that men can have breast cancer, but it's rare. It doesn't happen that often.
Okay.
We are all men and women. We are all born with some type of with some breast tissue. With men, it's just not a lot. But in the United States, so let's talk about statistics. This year, let's see, women over
hmm
300,000 women this year alone in 2024 in the US will be diagnosed with an invasive breast cancer. When we talk
Mm.
about men, it's rare. They only account for about
Mm.
1% of cases diagnosed. So we estimate that for this year to be approximately about 2,800 men.
Okay.
Now, again, it doesn't happen that often,
Hmm.
but it is something to be aware about, especially if you have a strong family history of breast cancer.
Yes. Yes. And I work in the healthcare field, and I work actually specifically in healthcare equity. And so I am thrilled to kind of be a part of this like big breast cancer initiative that's going on at my job. So I'm a little bit educated, not completely.
Sure.
But one thing that I do know when it comes to healthcare equity is that women of color, specifically African American women, we die at larger, greater rates than other ethnic groups. Can you maybe speak and maybe shine some light on why that is potentially, or I'm not
Yeah.
sure.
So many people might not realize, but with breast cancer, specifically breast cancer, white women are more likely to be diagnosed with breast cancer here in the U.S. All right, but Black women are more likely to die from breast cancer in the U.S. So the rate is startling in that we're not as commonly diagnosed, but we die more often, and that's due to a lot of different reasons, right? One could be socioeconomic reasons, such as access to care,
Mm-hmm.
or even if you do have access to care, then sometimes, whether we're talking about breast cancer, we're just talking about general illnesses. Sometimes women of color, specifically Black women, when we go in about issues that we have, sometimes we're not taken seriously, sometimes we're not treated appropriately. So that is actually could be a factor as well. Sometimes it's just that women don't have insurance.
Mm-hmm.
Um, or sometimes it's just in our community, sometimes we view certain illnesses as taboo. Nobody wants to talk
Yeah.
about it. No one wants to go get checked. We're afraid. We don't want to find out. Um, which we have to educate each other
Yeah.
to let people know that it's just much more better for us to know. You want to know, because the
Mm-hmm.
earlier you know, the best treatment that we can do, the more that we can help.
Mm-hmm.
So there continues to be a disparity with specifically Black women in treatment, being diagnosed, and then even with treatment, depending on where you go, unfortunately, some things that are offered to other uh, groups, ethnic groups, or racial groups are not being offered to minorities. Um, it's the disparity is there, the literature is there, we know it's there,
Mm-hmm.
and we're just trying to do as much as we can in terms of education, having people feel more comfortable. If you have a problem, appropriately, you
Mm-hmm.
seek a second opinion. There's nothing wrong with that, and you just have to advocate for yourself, because we know it's a
Yes.
problem, and we just need to advocate for ourselves.
Yes, that is a huge. Um, I wanted to kind of talk about takeaways at the end of each kind of
Sure.
segment, but that is a huge takeaway. Advocacy is huge, and I think even the part about educating ourselves once. Even before, like, right, this is an
Yeah.
educational platform where right now we are bringing awareness and talking about what we'll get to kind of like the different treatments and preventative things, but overall what breast cancer is. I think this is advocating for oneself is probably a huge takeaway when it comes to taking ownership of your medical care, right? And
Yes.
that's what I've learned so much about just in doing this healthcare equity work. So thank you for saying that.
Sure.
Can we go on really just shift a little bit and talk
Sure.
about some of the preventative
Yeah.
measures as it relates to cancer? Like, what is it that women of all walks of life, all racial, ethnic groups,
Hmm.
what are some things that we can do to maybe prevent that big diagnosis of breast cancer?
Sure. So prevent. There are things that we can do that we can at least decrease the risk.
Okay.
In regard to breast cancer, we divide it into two different categories. We have risk factors that we can do absolutely nothing about, and then we have risk factors that are modifiable. Risk factors that are not modifiable and it increases your risk is just being a woman. And as we get older, there's nothing we can do about that. We can't change our DNA. We can't change our family history. If you have a family history of breast cancer, especially in your mom or your sibling, your risk can be doubled.
Yes.
If you have breast cancer also, and it's in your DNA, so there's nothing we can do about that. Other factors that we take into consideration because we know it increases risk is, if you've ever been pregnant, did you breastfeed? How old were you when you had your first menstrual cycle? How old were you when you went into menopause? Because, we're concerned about that period of time that you were exposed to hormones. So the younger you are with menopause and with menarche, and the older that you are in menopause, you went through a very long period of being exposed to hormones, so that can increase your risk. One thing that I just want to mention that I think is really important is having dense breasts. So dense breasts is a risk factor for breast cancer. So we hear about it, we get a little nervous about it, but all women, we all have had or still have dense breasts at some point in our lives. It's nothing new. It's just that in the past, maybe a couple of decades, it was mandatory in quite a few states, and I think maybe even nationwide right now, that when you have your mammogram, we have to list on your mammogram the density of your breast. So more people are becoming more educated about it. So when we say you have dense breasts and it increases your risk of breast cancer, it's just that the components that make up the breast, which is the milk ducts, like I mentioned, the lobules, like I mentioned, there are other what we call stroma, which has connective tissue. It had blood vessels, nerves, fatty tissue. Everything makes up the breast. So as we get older, most women tend to lose the parts of the breast that we no longer need because we're not going to get pregnant. We're not going to be breastfeeding. So we lose those components of the breast, and our breast becomes much more fattier. Now, until we get to that point, when you have a mammogram, it's sometimes it can be a little bit difficult for the mammogram to penetrate the dense tissue. So if you have we may miss it on mammogram if it's really tiny because of the density of your breast. Now, we have made a lot of improvements in our technology in terms of screening, and we have different types of mammogram screening, specifically 3D mammography, that we know is helpful for women with dense breasts. And also, we also incorporate adding ultrasounds to women who have dense breasts, just so that we're not missing anything. So the ultrasound is important to know that ultrasound is an adjunct to the mammogram. We don't do just ultrasounds alone, because ultrasound alone cannot detect specific changes that a mammogram can. So that's the importance with dense breasts. But factors that we can change that are in our hands, and we're concerned about lowering our risk of breast cancer is just really general factors that we know about, that we hear about for generalized health, right? Eating a healthy diets rich in fruits, rich in vegetables, rich in whole grains, staying away from too much red meat, fried foods, fatty foods. All these things can play a role in helping to decrease your risk of breast cancer in the future. Exercising regularly, especially if you're postmenopausal, losing weight is really important. We know that that's a risk factor for breast cancer. And limiting alcohol intake. These are the big things that we know that can help to decrease your risk. So if women are really concerned about the risk, sometimes we focus on the things that we cannot change, that we cannot modify.
Right.
But it's a lot more importantly to see what we can do to make changes in our personal lives that can help to decrease that risk.
Yeah, and just in full transparency, so and I do would love for you to answer the question about the recommended age for like testing and stuff like that. But this year my mammogram resulted in a diagnostic test. I've been getting mammograms for the last 6 years. And this year I was told, okay, you need to come back. Your breast tissue is dense and we need to do a diagnostic. Um, and it was scary. Just, it was a waiting period of like
Yeah,
4 weeks
yeah,
before I can get back in, or maybe even 6 weeks.
yeah,
Then you have to get the diagnostic, and then you have to wait for the reading and all of that stuff. Thankfully, everything came back. They cleared me, and I too come from a cancer runs strongly in my genetics. So I have one auntie that had breast cancer like 3 different times. She's
sure.
still alive. She beat it every time.
Mm-hmm.
But can you talk a little bit about testing and what tests do you recommend, and what age do you recommend for women to start being tested regularly for mammograms?
Sure. So there are a lot of different guidelines out there that have different recommendations. Um, I personally, and not just myself, but other organizations also, we recommend that women who are average risk, that we start screening mammograms at age 40. Now, there is an organization that had recommended you start it at age 50, and after that you do it every 2 years, which many of us physicians and even other organizations didn't agree with. But because we felt that if we were to start at age 50, I mean, we would be missing out on some women being diagnosed with cancer. I mean, specifically minority women, right? Because when Black women have breast cancer, unfortunately, sometimes we get it at younger ages,
Yes.
and we would be missing out on those women. So we advocate for women to start at age
No,
40.
that
Now,
I
this
mean,
is for,
yeah, that makes a lot of sense. And it's breaking. I hope I'm not breaking up, but it's breaking up just a little bit,
oh,
doctor. But
sorry.
no, it's, and I don't want to cut you off. I want to make sure that you get, all of your points
Sure,
across.
sure. So I'm sorry. I'll just mention again that my recommendation, as well as some organizations, is to start at age 40 for average risk women. But the question is, who's average risk, right? How do you know what your risk
Mm-hmm.
is? So that's a huge thing that we're trying to work on, and doing risk assessments on patients.
Mm-hmm.
And risk assessments basically lets us know what your lifetime risk of you developing a breast cancer is, and or even like your 10-year risk. It's based on your family history. It's based on your density of your breast. If you ever had a biopsy, what the biopsy results are, and all of the other factors that I mentioned in terms of the risk factors for breast cancer. And we come up with a number, and we see, well, if you're high risk, then we need to do something else. And that something else sometimes is adding breast MRIs.
Mm-hmm.
Now, to start with, you start with your mammogram. You start with a screening mammogram if you're not having any issues, and that is standard and that is routine. If you have dense breasts, we at most places we also do a screening ultrasound. Now, if there's something that is found on the screening mammogram, that's when you come back for diagnostic imaging. And diagnostic imaging is basically just to focus on that particular area so we could get a better view. And yes, you're right. It is a scary moment. It is a scary time. Um, Most of the time when there's something that's suspicious found in imaging, most of the time it's okay. But, many times it's not. So the recommendation is start at age 40 for average risk. You should speak to your physician, your doctor, about having a risk assessment done so you could know your
Yes.
risk, because many times, I mean, we just don't know. We don't know until we actually do that calculation. So see, because if your mom had breast cancer at age 40,
Mm-hmm.
then you shouldn't be starting mammograms at age 40. The recommendation is to start 10 years younger. So you should be starting at age 30. Actually go and speak to your doctor about it, or you see someone like myself who deals with women that are high risk.
Okay, that makes sense. One of our roommates actually just shared her story as well, saying that this year also she was recommended for a diagnostic. So similar to what I said, and she also said that everything came back good. So I'm really, happy to hear that for her. Um, so what are some things that a person can look for to try, like in their physical space? I mean, I know growing up from a young age, my OBGYN or my PCP would tell me, like, do your breast exams and stuff like that. But what are some things outside of the medical home and being with your doctor and taking your doctor recommendations can you do to maybe try to feel for and familiarize yourself with your breast and if something is shifting or changing?
Yeah. So we kind of call that like breast health awareness or breast awareness. You want to become familiar with your breast, know what they feel like, um, and know that if you notice any changes that's different from that you haven't noticed before, that you want to be evaluated. Um, I don't recommend to do breast exams every day.
Mm-hmm.
Just once a month, I think is good enough.
Mm-hmm.
And just you basically just looking to feel if you feel anything that feels a little bit different, any lumps in the breast. I will say that majority of the time when women come in with a lump or a new diagnosis that's palpable and you can feel it, it's they themselves felt it themselves, or usually maybe their partner
Mm-hmm.
felt it, but they felt something that felt a little bit different. So looking for a lump, and also any changes in the nipple discharge, any changes in the skin.
Mm-hmm.
Sometimes if it's located so under the nipple,
Okay.
then that cancer evades the skin or the nipple, and it can pull the nipple inwards. We say retract the nipple inwards, or sometimes it could retract the skin inwards. So these are skin changes that we look for to see if anything is suspicious. So anything of the sort, anything that looks different.
Mm-hmm.
But just know that even if you have a lump in the breast, even if you have a nipple
Mm-hmm.
discharge, even if you find these changes, it doesn't necessarily mean it's due to a breast cancer,
Mm-hmm.
but we always need to evaluate it just to make sure.
Okay.
And also, it's important to mention that sometimes, we feel a lump in the breast, but sometimes the first thing that people notice is a lump under the arm, right? That's where the
Mm-hmm.
lymph nodes are.
Mm-hmm.
So sometimes that is the initial presentation
Mm-hmm.
of breast cancer also.
I can attest to that. When I told you the story earlier about my aunt, it was
Mm-hmm.
pain up under the arm and feeling of a lump
Yeah,
up under there. So uh, can we shift a little bit and
sure,
then let's talk um, to the audience of people who are either experiencing cancer now or have experienced cancer in the past, and like what are some of the treatments? Like I've heard of mastectomy and I'm not going to try to
sure.
say the L word, right? But I've heard of the different like treatments or surgeries, right?
Sure.
And so with you being a breast surgeon,
Mm-hmm.
tell us, like, what does that look like? What do you look for when you come in and recommend breast surgery for someone? And what is it that we should know about the different types of surgeries and treatments and things like that?
Sure. So as a breast surgeon, usually we're the first person that where the patient sees them about everything from ranging from their pathology, to the imaging and to the possible recommended treatments. Uh, so everything depends on the stage of the cancer and also the biology of the cancer.
Okay.
When we treat breast cancer, there are different modalities. Surgery is one of them, radiation therapy, and then chemotherapy, and then we have hormonal therapy. Then we also have a targeted therapy also, but we kind of put that immunotherapy, we put that in a category with chemotherapy. Now, in some cases, some women, unfortunately, may need all of those treatments,
Mm-hmm.
whereas some women, maybe with earlier stage breast cancer and the biology of the cancer is much more favorable, may not need all of that treatment. But those are the different modalities. I think we have come a long way with treating breast cancer.
Mm-hmm.
We know that more surgery isn't always necessary, and we have cut down on a lot of the surgeries that we've done what we used to do in the past that we don't do anymore because medical treatment have become so more advanced these days. So, but surgery still plays a role. When you surgical options, like you mentioned, includes a lumpectomy. Lumpectomy is if you just have a mass that's pretty local. It's localized. It's not that large, and we just go in and remove the mass and we leave the rest of the breast intact. And then the other option is a mastectomy, where we actually remove all, okay, not all, but majority of the breast tissue. And sometimes we take the nipple, sometimes we can leave the nipple, depending on the circumstance. And some women choose to have reconstruction right after the mastectomy, which is using an implant, whereas some women decide not to.
Okay.
And then depending on what you choose from a surgical standpoint or the the biology of your disease is recommended. Chemotherapy is something that many women, we know from the start when we see them, depending on the biology of the cancer, that we know chemotherapy plays a big role, and we know that it'll be very helpful. Whereas we have some women that we're just not sure, and we need to do surgery first, and we need to re-examine the mass, the malignancy, to see if chemotherapy is truly necessary. But I just want to mention something about chemotherapy. No one, when we talk about chemotherapy, it's nothing pleasant, right? But no one ever wants to have to go through that treatment.
Yeah.
But in many cases, especially in Black women, because we tend to have more aggressive type of breast cancers, and we know that the chemotherapy can work very well in these type of cancers. I always urge my patients to really, really think twice about declining chemotherapy.
Okay.
Because it could be the most important treatment to help you fight this breast cancer. So while we know that it may have some side effects, we know that the benefit outweighs the risk. So it's a very, very important part of treatment. Women do it all the time. They make it through it, and they do well. So when we're thinking about survival rates, everything is based on you doing the recommended treatment. Endocrine therapy is, as people probably heard about it, as being called a pill. It's a pill that some women may qualify to take, and it's a pill that you take once a day, and it helps to decrease your risk of breast cancer coming back in that breast. So also you having a new breast cancer in the other breast. You take it for at least 5 years in most women.
And then as far as like the types of surgery.
Yes.
So I have a friend, and I'm sure, many of us may know different people who've had their different bouts with cancer. So when the recommendation, like the removal of breasts, like, can you kind of help us understand what is happening there, and how do we reach that level of recommendation?
I'm sorry, you kind of went out a little bit. I'm sorry. You're asking about, you mean
So
when
like,
to perform surgery?
some people can go through those localized surgeries and get the chemo and take the pills and stuff like that, but some people have get to that place where they have to have their breasts removed, sometime one, sometime two. So what is happening when you've reached that level of recommended treatment, or
So it depends on the so breast cancer have, again, different biologies. Some could be a little bit more aggressive, some could be less aggressive. Now you can have we don't base surgical treatment based on the aggressiveness of the disease. So if you have a small mass and it's amenable to a lumpectomy, regardless of the biology of the disease, we would recommend a lumpectomy. And when we treat breast cancer, also, in addition to treating the breast, we also remove some lymph nodes under the arms, also, just to check to see if the cancer has spread to the lymph nodes. Cases where we would recommend a mastectomy to remove the entire breast, if you have a pretty large mass, that would be the recommendation.
Doc, you went out right when you were about to say cases where the mastectomy is recommended.
Yeah. So mastectomy, we usually recommend a mastectomy if there's a really large mass. Okay. And but in some cases, if the mass is really large, sometimes the recommendation is to do chemotherapy first and the chemotherapy can help to shrink that mass to a more amendable a size that's sometimes even more amendable to doing a lumpectomy. Um, if the cancer has involved the skin, um, depending on how widespread, if it's diffuse, we would recommend a mastectomy. If the cancer is extensive in the breast and it's throughout different areas of the breast, then a mastectomy would be a mastectomy to do on in the other breast.
Okay.
We don't routinely advocate for removing the other breast if the other breast is healthy. But there are circumstances where we would, and that would be if you have genetic testing and we see that your genetic testing shows that you have a gene mutation that increases your risk for a future breast cancer,
Okay.
then that is certainly a conversation that we would have to consider removing the affected breast as well as the other breast, and we can always do reconstruction of both sides. So we have gotten a long way from doing mastectomies for every single woman. Back 50 years ago, that's what we did, and we know that it didn't improve survival. Women didn't live longer. We know with the treatment modalities that we have today, women can do just as well with doing less surgery.
Mm-hmm. Whew. That is really intense. I've heard people who've had mastectomies, or I hope I'm not saying it wrong. But
Mastectomy.
mastectomy. Okay.
Yes.
I've heard people who've had that surgery and the removal
Yeah.
of the breast talk about phantom pains.
Yeah.
Can
Yeah.
you maybe kind of help us understand what phantom pains are?
Anytime you do any type of surgery,
Mm-hmm.
you will experience unfortunately, some people have pain and they could have some pain chronically. And many times it's not pain that is, we say it disturbs your lifestyle. Excuse me. Pain that disturbs your lifestyle per se.
Okay.
But sometimes you might have what we might say some little shooting pains every once in a while. And a lot of times this is just due to nerve pain. Not everyone experiences that. It is something that can happen after surgery. Uh, Sometimes we hope it doesn't, but a lot of times there's nothing we can do to try to help to prevent that.
Absolutely. Before we wrap this thing up and you give us, information about where we can find you and stuff like that, do you have any key takeaways that you really will want my roommates or any of our other audience members who are listening now and who will listen futuristically, because we will post this to like YouTube and other places? What are some really key takeaways that you would give just men and women as it relates to breast cancer and anything related to that?
Sure. The most important thing I think is spreading the word and educating people about breast cancer and the risk factors or things to look for, and just letting people know that it's okay to go and get things checked out, and it's not taboo to be diagnosed with breast cancer, and you should share that diagnosis with family members. Sometimes we keep it to ourselves, and then other family members don't know. You don't know their history, so they may not know that they're high risk. Early detection,
Yes.
Mammograms, get them consistently, get them on time, get them once a year, get them starting at age 40 if you're average risk. The other thing is just things that we can do is, exercise, eating healthy, limiting alcohol intake. And then just a couple other things, these are just kind of myths that people may talk about with breast cancer. People talk about deodorants, certain type of deodorant that you may use that may cause breast cancer. And as of today, no literature, there's nothing out there to show
Okay.
that certain type of deodorants can increase your risk of breast cancer.
Okay.
Maybe something like women might say, if you wear underwire bras, I've heard that before. Does that increase your risk of breast cancer? And nothing has proven for that to increase the risk of breast cancer.
Okay.
So early detection.
Well, we came tonight ready to stand in the gap with people, educate them, talk about that advocacy. I brought my gloves. I need to go. I need to go and do some boxing. I was like, this is so fitting to knock the dust off of them, which I really should be somewhere using them in real life. And I just wanted to not allow October to close out without bringing forth a professional and a specialist who can speak to breast cancer so eloquently as you have done today here. Um, I want to thank you, thank you, thank you. This is, again, I just don't know. Words can't express it. I'm just really excited that you were able to join us. Roommates, Dr. Patrick is on the other side of the Atlantic Ocean. I'm not going to tell her business about where she's at. And she is 6 hours ahead of us, and she stopped what she was doing to come and grace us with her presence and her knowledge. And for that, we need to be saying thank you. And Dr. Patrick, if you can please tell us, though I have it pinned
Sure.
here in the comments, can you please tell us everywhere, anywhere that we can find you so that my roommates, so that we can support you and get the treatment that we need by people who look like us and understand us as a people?
Sure. So my website is www.serenitybreasthealthandwellness.com. And email is serenitybreasthealth@gmail.com. And I am also on TikTok and on Instagram, and I do videos on there, again, educational videos. There are a lot of educational stuff on my website also that would be good for people to check out. I'm sorry, I have to check what my Instagram is.
Okay.
So
It's
it's
okay.
actually, let's see, Dr. Dr. Jilma Patrick, and that's on Instagram, is at breast health wellness BHW on TikTok, and then on Facebook it's just Dr. Jilma Patrick on Facebook.
Yes. And I have it pinned, and I'm going to keep it pinned. And actually, when I upload it to other platforms, I'll make sure that I pin your information.
Sure.
Because, I've done a lot of my breast cancer testing and all of that stuff through my OBGYN, who you know, and
Yes.
and my PCP.
Yes.
So, but, if I have to cross that path and know someone that has to, I definitely will be, referring them and giving them your information. And I just want to close with another Bible verse before we close out.
Sure.
Roommates, this is coming from Jeremiah 33:6. Behold, I will bring I will bring you health and cure, and I will cure them and will reveal unto them the abundance of peace and truth. Roommates, please know and recognize that you are not alone. Even if you feel like you don't have people that you can talk to, or you want to go into a lowly place, and I know how sometimes we like to disappear when we're going through. Understand that there are support groups out here. Understand that you have me at any turn, at any juncture. These pink gloves literally symbolize creating yourself a community to fight with you and on your behalf. I am praying with and for any of you guys that are going through. And I thank God for Dr. Patrick for gracing us with her knowledge and her presence. I am forever grateful. I thank you so much, Doctor.
You're welcome. Thank you for having me.